We've got a large number of questions, it looks like. A significant number. I wanted to start off with a question for Sam, which is, what would her advice be to physicians who don't have the benefit of a KidneyPal program? How can they, what literature can they use? How can they work with whatever palliative care they have locally to create the equivalent?
That's a great question. So, two ways to answer it. One, how do you build your own primary palliative skill set, which is the idea of all the palliative skills that every nephrologist should cultivate and have. And I think there's some good resources out there, including the core curriculum in AJKD on kidney supportive care. That's a case-based quick read that I would strongly suggest. There's an ISN curriculum that goes really into deep detail on symptom management, that is a free online curriculum. It's mostly like static slides rather than interactive, but it's pretty good and it's free. It's called a Kidney Supportive Care and Conservative Management Curriculum. If you're looking to build a KidneyPal service or a collaboration, I think some of the studies that I showed that our team has put out is a good place to start in terms of how do you do a needs assessment, how do you make a financial case for it. And then I would just reach out to your palliative care consultants, ask them, do they take non-oncology consults? Because some places still don't. But if they do see patients with non-oncology illnesses, I would start to invite them with you into some of your hardest rooms. I would invite them to see the kinds of goals of care conversations that you are having and that you're struggling with, and invite their perspective. I think they can learn a ton from us about the kinds of things our patients go through, and it varies a little bit how comfortable they'll be, given that much of palliative care is sort of trained on oncology. But starting by asking them to come with you to see a patient, ask them to come to a case conference if you're presenting a particularly challenging one. Those are good ways to initiate relationships and see whether you can build into a more sort of productive partnership.
Yeah, I think the collaborative approach is the key issue, that it's, let's have a meeting before we walk into the room. Let's make sure we're on the same page, and some degree of beforehand collaboration is very important. And as I said, it's become an incredible part of our clinical program at the Brigham. And Sam, I should say, has been part of our population health program for chronic kidney disease management. And that was deliberate because in terms of asking her to be involved with that, in that the patients that have the biggest trouble on that transition from CKD5 to ESRD really benefit from KidneyPal involvement in those difficult conversations and having those and working that into a program in addition to KidneyPal. Let me pull up some of the other questions. So for Opie, first question, would you recommend testing the young African American ESRD patients seeking kidney transplant? I presume obviously for APOL1.
Yeah, so this is looking at recipients. The abundance evidence, most evidence suggests that the genotype of the recipient does not matter. Now, I would say that is not a consensus. There's one group that suggests it may, but for now, I think the large field feels very strongly that the genotype of the recipient does not affect the ultimate outcome of the allograft. So for now, I would say no. The evidence does not support that.
Okay. The other question, I think I saw. And the other question was, could APOL1 explain the high risk of FSGS recurrence in the transplanted kidney?
So that's a very good question too. The answer is actually no. So it turns out this has been looked at. it turns out that if you look at FSGS recurrence, it's actually higher among non-Blacks. And when you look at the contribution of APOL1, it's not there. So APOL1 does not increase the incidence of recurrence FSGS. Recurrence, I'm thinking of circulating factor FSGS. That's really not what we see.
Okay, I'm going to take the chance to put you on the spot here. So I got really excited by particularly the JAMA paper on the M1 variant in March.
Mm-hmm.
I don't quite understand the genetics, how that only, what do we know why we only see that in G2 alleles, and how did it arise?
Yeah, so that's a great question. So Martin, as you know, is the card carrying geneticist. So it turns out that the N264K originally was on a G0, and over time, through some admixture, it jumps also on G2. So only G0 and G2 have it. But for G0, it doesn't matter because G0 is not associated with it anyway. But if you are lucky, you are G2, and your G2 happen to have the N264K, you hit a jackpot. But it's just so rare. It's not common. Now, if you're in a parasitic endemic area, which is how it was discovered in Ghana, somebody presented with recurring parasitemia, and somebody said, why is this person presenting with trypanosomiasis? In this context, they sequenced this person's genome and they found that the G2 has this new SNP. And functionally, when you look at it, it turns out to be a dead G2. So it's present in G0 and G2, but from the point of view of disease, G0 doesn't really matter anyway, but only in G2.
So we've had an interesting dialogue with some of the more prominent genetic testing companies who shall remain nameless. They are not reporting M1 alleles.
They should be.
I know. So there's a cynical explanation for that, which I won't go into. But one of the companies said, well, it's not really clearly a disease-associated allele. And so we're not really saying that. We're saying it's a protective allele, and you should be reporting it.
Absolutely. So if your patient has a G1, G2, there should be a trigger to testing that patient for N264K. In the Justice trial, when we are testing baricitinib, anytime we have a patient that is a G1, G2, or a G2, G2, we reflexively test for G2, and we actually disenrolled one patient on the ground of having 64K. If that, because that disease is not driven by APOL1. So they should be, for a patient that has G2, it should be offered.
So more to continue. So moving on, thanks, that was terrific. Sorry. Pulling up the other questions. Sorry, the Springers are misbehaving here. So one question for Garode, is there concern for significant hyperkalemia or initial creatinine decline with finerenone?
I think that the data from the clinical trials, it suggests that it's not as bad as the steroidal MRAs, but I think real world will show us that that's different. If you remember the classics trials of spironolactone, where there was a small incidence of hyperkalemia, but in the real world, once they started using it in a lot of patients, there were a lot of patients who turned up in the ED with hyperkalemia. So I think it'll be probably somewhat similar. So it's something you need to monitor after you start the drug. But hopefully it'll be less than it would be with the steroidal MRAs. Similarly for GFR decline, mechanistically speaking, there shouldn't be as much as there would be with for example, an SGLT2 inhibitor or a RAS blocker, but potentially a small amount.
Yeah, one of the trials also had a protocol where you'd start at 10 milligrams and then repeat the Chem7 and then increase to 20. And when you did that, there was so it should be sort of gradated starts, but spironolactone has a metabolite that accumulates in CKD4, so that's the other issue that gets to be a problem. Um, the other question, next question. So for Dr. Chaudhuri, any treatment in ALEC2, I have a patient.
Yeah, so ALEC2, there aren't any disease modifying treatment at this time. It's made in the liver, and we still don't know why certain populations make ALEC2 from the liver. So once again, the population is being Mexican ancestry, certain Egyptian cohorts, and then of course northern India. Now, phenotypically, ALEC2 is fairly benign. It's slow, progressive CKD, not this rip-roaring nephrotic syndrome or AKI that you'll see with other types of amyloidosis. And the percentage of people that progress to ESRD is actually fairly low, only 20 to 30% in a 2-year rate, as opposed to 50 to 60% and upwards for light chain amyloidosis without treatment. So definitely there is a renal survival benefit. There's a overall survival benefit, and no, unfortunately, disease modifying treatment at this time.
The next question for you, Rod, is do you take the lead in performing tissue diagnosis before the hematologist? In my practice, I end up doing the kidney because heme is not cooperative. That's an important issue.
It's a very important issue, and I think it's very center dependent, right? It comes with sort of what expertise you bring to the table and sort of how you develop your equity with your colleagues. I have to say the foundation of what we do here, it comes down to renal pathology and hematology pathology. We all get in a group and we talk about the diagnosis on a kidney level and a hematological level. I will say if it's a complex MGRS, I will usually manage and sort of lead the charge or quarterback it. Usually amyloid, my hematology colleagues will sort of lead the charge because it's so systemic. But it's very sort of center dependent. We have a very good working group here at the Brigham and Dana-Farber.
And it's also evolved over time. It used to be very difficult. Now I think when you have colleagues that have seen more of these MGRS renal pathologies, they're a lot more receptive than they were, say, 10 or 12 years ago. Next question for Dr. Jalal. Is rituximab helpful in resistant ICI-associated interstitial nephritis? And is there any benefit with infliximab or MMF if GFR already impaired on steroids?
So I guess I'll answer that question in reverse. So I've personally have had very limited success with MMF and typically don't reach for it. Similar with tocilizumab. Infliximab has actually been quite effective for me in steroid refractory cases. In fact, I've got a couple of cases, one in particular where the patient went to creatinine of 10 twice. He kept getting AKIs, ICI AKIs associated with antibiotics. So went to creatinine of 10, and both times after infliximab treatment, we got his creatinine back down to 1. In terms of rituximab, so we don't have great data for rituximab with ICI-AN. In fact, it's non-existent. There is limited data with rituximab use in ICI-associated GNs, but most of these are small case series, less than 10 patients. I think the only thing that kind of needs to be clarified is what sort of impact rituximab would have on antineoplastic objective response rates. Theoretically, it shouldn't have very much because these are B-cell depleting agents, although there is some crosstalk with T cells. And some studies have suggested that, with rituximab, you shouldn't experience any decreased efficacy of these antineoplastic agents, although in some of these case series with the ICI-GNs, there has been some disease progression. So this is something we definitely need more data on.
And my recollection is the MGB onconephrologists have got a recent NIH trial to study infliximab for ICI-associated IN. So we'll have a bit more rigorous study down the road.
We're starting to use it a lot more first line. And so I think the trial will be looking at infliximab first line versus steroids first line.
Okay, next question, and this is a really important one and dovetails into other questions about GFR measurement. But how do you approach patients on immunotherapy coming with divergent cystatin C and creatinine?
So that's a great question. Some centers are very fortunate in that they can perform a measured GFR, and so that'd be ideal. And so, I mean, that'd be the gold standard. But in the absence of that, I think obtaining a 24-hour creatinine clearance would be the next best step. I mean, oftentimes, we recommend using the combined equation. But one thing to keep in mind is a lot of these chemotherapy protocols that have been established have been based off of Cockcroft-Gault. So, what I think it depends really on the clinical scenario and really how big the divergence is. But I think a 24-hour creatinine clearance is a good first step.
Right. And the other issue is methotrexate. And what GFR do you use to guide dosing? And, I know Shruti is very interested in that particular question.
Yes.
Okay.
So methotrexate toxicity. What we've started to do in our center is actually use prophylactic glucarpidase. So patients with advanced CKD or patients with solitary kidneys with elevated creatinines, we actually have started to give them prophylactic glucarpidase with some good effect. Oftentimes these patients need multiple cycles of high-dose methotrexate, and despite it being such an old medication, it really is one of the most efficacious in terms of CNS penetration. And so, we don't want to be in a situation where we withhold methotrexate. And so, in my eyes, even though it is a very expensive medication, the cost of dialysis or prolonged hospitalization is much more.
All right. And I think we're going to have one last question before we wrap up, just before 7. And again, it's for Dr. Jalal, still on the hot seat. So I have a 69-year-old woman with sinonasal cancer on repotrectinib with a sodium of 143 to 148, drinking about 3 liters of water a day. She is CKD2. This is a known side effect, but is there more on the mechanism? Thank you.
Okay. So that's a great question. So I am personally unaware of any intrinsic renal manifestations of repotrectinib. My understanding is it primarily causes nausea and diarrhea. And so I'd be curious if there's an element of volume depletion. But I mean, listening to the case, if the patient's drinking about 3 liters of fluid and is still hypernatremic, I mean, I would look at whether or not there's an ADH abnormality or whether or not there's an osmotic diuresis. But I think this is the great part about onconephrology, in that you have all these new cancer agents with unusual side effects, and you're constantly learning. And I would look forward to potentially reading about this case in a journal at some point in the future.
It depends on your perspective. If you're an amateur onconephrologist who has to pinch hit once in a while, it gets a little bit harder to keep up. Is this one of the RAS inhibitors?
So it's a small molecule tyrosine kinase inhibitor used in I think ROS1 fusion gene. So with the small molecule tyrosine kinase inhibitor, they're usually not associated with hypernatremia. So it would be an unusual side effect, but all these drugs have unusual side effects, and it certainly wouldn't be unsurprising.
Yeah, we're seeing some of these RAS inhibitors in the pancreatic cancer patients, and they don't seem to be very well tolerated in terms of the nausea and vomiting associated with them. But
yeah,
my week of one recently,
especially the new one, the Daxro.
Yeah. Okay, I think we're good. This was another amazing afternoon. Thank you all, and we'll see all the participants back tomorrow. Thank you.
Thank you.